Okay, sorry about last week. Had a few technical troubles, but I think I've got them sorted now. Um, the last film I showed you last week was a patient who's got allergic bronchopulmonary aspergillosis. It's the finger and glove appearance of the bronchioles that are emanating from the hilar region, and you can see them here on the lateral, and they're better defined on the PA film. And the CT scan demonstrates these branching tubular opacities which contain bronchial fluid in these bronchioles. So allergic bronchopulmonary aspergillosis is one of the aspergillus-related lung pathologies, and it's a hypersensitivity reaction to the fungus, which causes bronchiectasis. So they get consolidation, and then the consolidation leads to bronchiectasis, and then you get the dilated bronchi associated with asthma and wheezing. Okay, where is this mediastinal mass? I can see the aortic knuckle just, and I can see the left heart border is obscured by this mass lesion. The right heart border is also obscured by the mass lesion. And there's either elevation of the right hemidiaphragm or there is a subpulmonary pleural effusion. And when we do the CT scan, it confirms that it is an anterior mediastinal mass. If you're going to do a biopsy of this mass, you want to avoid the internal mammary vessels. You can go between the sternum and the vessels or lateral to the vessels, but not obviously into the vessel. There's the mass lesion here, which you can then appreciate on the chest radiograph. Another example of an anterior mediastinal mass. This time we can tell it's anterior on the lateral because we've got filling in of the airspace, and we've got the hilar structures, in other words, the blood vessels are still visible, and yet there's a mass lesion in the atrioventricular groove, and we've got loss of the right heart border, yes, again, because of an anterior mediastinal mass. So this also turned out to be lymphoma. Don't forget lymphoma. We've got neck nodes here, which are seen on the CT scan. But looking back on the plain film, you can actually see that the neck is swollen. So don't ignore lymphadenopathy in the neck. It does give you a clue as to what might be going on in the mediastinum. And here is the CT going a little bit lower down. We've got an anterior mediastinal mass lesion, very marked tracheal narrowing, which you can see on the chest X-ray, caused by the contiguous anterior and middle mediastinal mass lesions. So this shadow here is actually the middle mediastinal component of the lymphoma. A little bit lower down, a little bit lower down. And you can see that the patient has effectively got an SVC obstruction. There's the SVC, which is very slit-like. There's marked compression of the trachea. And we've got dilatation and enhancement of the chest wall vein on the left-hand side. Why is it on the left and not on the right? That's because the patient has been injected on the left-hand side. Okay, so there's the brachiocephalic vein on the left, there's the aortic arch. And there's the aortic knuckle, clearly seen, separate from the mass lesion, because in the aorta, there is aerated lung adjacent to it at that level. That's why you can see it. So this is an anterior mediastinal mass due to lymphoma. This just gives you a feel for all the lines and stripes and interfaces that you can see, because we've got both an anterior and middle mediastinal mass. Now, if you get anterior and middle mediastinal masses coexisting together, that's almost always due to lymphoma, because of course lymph nodes affect or are normally seen in all three compartments. Okay, this is what's called the aortic nipple. So there's the aortic knuckle, and then there's a little nipple-shaped structure just adjacent to the aortic knuckle, and that is a dilated left superior intercostal vein. And you can see it just here. Now, it may be dilated because the patient's doing a Valsalva's maneuver, or it may be dilated because the patient's got SVC obstruction. In this particular case, it may be that the patient is doing a Valsalva's maneuver, and you can see that it goes from anterior to posterior. So it goes from the brachiocephalic vein and it drains the hemiascus vein. Okay, what's going on here? Patient is fairly well, and they have a routine chest X-ray. Any thoughts? Yeah, so there's a lesion projected over the right upper part of the chest. It's above the clavicles, it's well defined. It could represent a skin lesion, or it could represent a posterior or middle mediastinal mass. This actually did turn out to be a neurogenic tumor. Okay, but I have seen sebaceous cysts look identical to this. Okay, so always be very careful about not overcommitting yourself. Now, this is an arterial phase, and this is a portal venous phase of a patient who has developed abdominal pain. What have we got here? Rectus sheath hematoma. It's involving the transversus abdominis muscle. We've got contrast pooling on the portal venous phase. That's a really good description. So if you go back and have a look at that portal venous phase, you can see that the contrast is more evident on the portal venous phase than it is on the arterial phase. And this is due to a bleed of the inferior epigastric artery. And you can tell that hematoma is some days old, probably because of the layering, and see how the demarcation doesn't cross the midline. So this is a rectus sheath hematoma, almost always associated with anticoagulation therapy. And the very fact that we can still see a bleeding point doesn't necessarily mean that the interventional radiologist has to go in and embolize the bleeding vessel, because it will eventually stop bleeding. Certainly don't put a needle in to drain it. That's the wrong thing to do. Excuse me. And if we look in the liver, there's also a liver lesion just here. Now, the liver lesion could be a hemangioma, or it could be a neoplasm, which is a bit more sinister. We haven't got enough information, really. Small amount of ascites. Okay, so in the same way, have a look at this one. This is a patient who presents with rectal bleeding. This is the unenhanced on the left, portal venous arterial. Let's play that again. So we've got contrast pooling in the cecum. It's persistent on the portal venous phase and the arterial phase. And so there's a bleed in the cecum. Angiodysplasia doesn't usually enhance with contrast, although that can also be associated with bleeding in the cecum. But this was a cecal bleed which required embolization to stop. There's another patient who's got rectal bleeding. And you can see that there is contrast in the sigmoid colon, which is more prominent during the arterial phase than the portal venous phase. So it doesn't always follow that the arterial and the portal venous phase are necessarily of the same attenuation. It could be the other way around. Okay, so this is a sigmoid bleed from diverticular disease. You can see the diverticular disease here, and there's obviously an arterial bleed because this is seen more prominently on the arterial phase. Okay, this patient presents with confusion and pyrexia, middle-aged female. Yeah, HSV encephalitis, temporal lobe involvement, doesn't tend to involve the basal ganglia, so it stops in the temporal lobe, and this was herpes simplex encephalitis. Okay, what have we got here? One slice. Esophageal mass, and what about the liver? Yeah, there's a heterogeneous liver mass just here. So we've got esophageal cancer with liver mets. Okay, where is this mass lesion? I can't see the aortic knuckle, and I can't see the left heart border. So it therefore must be involving both the anterior and middle mediastinum. So it's so big, it's involving both the anterior and middle mediastinum. And you can see it just here. So if I draw around it, it's going to be just that's the mass lesion. And of course, the aortic knuckle is going to be here. So it's going to be about there. So you don't see the aortic knuckle because this mass lesion in red is superimposed over the aortic knuckle, which is in purple. So you just don't see it. And because it's so big, it also obliterates the left heart border. And this turned out to be a dermoid cyst. but it was so large that it involved both mediastinal compartments. Oh, sorry, I didn't realise I'd already drawn something to demonstrate this. Okay, so this is a cyst involving the anterior mediastinum. It turned out to be a dermoid cyst. Okay, what have we got here? Patient presents with right-sided pyramidal. Yeah, anterior cerebral artery territory infarction. Okay, so there's a blockage of the anterior cerebral artery. Patient with a cough. Oh, sorry, yeah, just to go back to that CT brain. Here is the low attenuation in a parafalcine position, and it just means that you've got an infarct in the territory of the left anterior cerebral artery. Right lower lobe collapse, no. Right upper lobe collapse. So let's have a look at the so we've got elevation of the right hemidiaphragm compared to the left. So we've got volume loss on the left. Oh, sorry, on the right. We've got the right hilum should be lower than the left hilum, and the hilar point is here, and the hilar point is there. And so that's been moved up, and there's the right upper lobe collapse. So if you're not sure, look for the secondary signs. So the right hilum has moved up instead of down. The volume loss could be present in both lower and upper lobe collapse. And the patient has clearly got right upper lobe collapse here adjacent to the upper mediastinum. And there it is on CT. There's the collapse right upper lobe. And the hilum has been pulled up, and we've got this volume loss, which is more apparent on the chest X-ray than this particular coronal scan. Okay, what's happened here? Patient is in shock. How do I know the patient's in shock? Well, they've got bright adrenal glands, so very dense attenuating adrenal glands, meaning that the patient is hypotensive, and they've got a spleen that is ruptured with hematoma around the spleen, and they've got hemoperitoneum. Don't forget the hemoperitoneum goes all the way around the liver, but doesn't involve the bare area of the liver, which doesn't have a peritoneal reflection. Okay, but everything else is fluid in the peritoneal cavity, whether it be the lesser curve or the greater curve. Sorry, the lesser sac or the greater sac, which in effect is the peritoneal cavity. So what's a spontaneous cause of splenic rupture? Well, it could be infectious mononucleosis, and it could be other conditions that cause stretching, acute stretching of the splenic capsule. But usually it's infectious mononucleosis. Okay, pacemaker, subpleural nodules, bronchovascular beading, sarcoid. So sarcoid could be cardiac sarcoid and pulmonary sarcoid. Okay, have a look at that one. So the slice here is through the supraorbital ridges, and then the slice here is through the pituitary. Put it all together. That's a coronal slice through here. Yeah, it's a macroadenoma, and it must be secreting growth hormone because we've got the supraorbital ridges are very pronounced. This is a case of acromegaly. Okay, what have we got here? It's not a super scan because we can see the kidneys. There's the left breast, there's the right breast. The left breast looks photon dense in the skin, and that's because the patient has got lymphatic uptake of tracer on the left side. The bones look reasonably okay, possibly something going on here, but the CT scan that accompanies this bone scan demonstrates a mass lesion here, and you can see the thickened skin of the breast. That's called peau d'orange. Peau d'orange, and it's lymphatic infiltration. Okay, what have we got here? Yeah, sarcoidosis. So we've got a patient who has got nodular meningeal enhancement involving the basal cisterns, Sylvian fissure, interhemispheric fissure, and the patient has also got lymphadenopathy in the mediastinum. So this is a patient who's got sarcoidosis, and it's granulomatous meningitis. Could it be TB meningitis? Yes, it could, but it would have to be primary TB because of the patient's lymphadenopathy. Okay, what's wrong with that chest drain? So the patient's had a chest drain put in on the left for this pneumothorax with a reasonably good result, bit of surgical emphysema here. The chest drain on the right-hand side has gone in, but nothing seems to have happened. Yeah, it's in the trachea. You can actually see it in the trachea. So 15 minutes, 2 chest drains have gone in, and this one's in the trachea. So what's probably happened is it's pierced the lung, it's gone into the right lower lobe bronchus, into the bronchus intermedius, into the right main bronchus, and then into the trachea. Okay, abdominal film, patient with weight loss. Any thoughts? The last case somebody was asking is a misplaced right intercostal tube in the trachea. Now, what is this here? What is that there? This is a patient who's got multiple lung nodules. Okay. Now, it may be tricky to see, but this patient has got lung nodules projected at the base. And when you do the chest x-ray, you can see there's one there. There's obviously the one that you could see here. There's one just there. quite difficult to see. But that's a definite lung nodule. So we've seen more than one lung nodule, 1, 2, 3, 4. And so this is pulmonary metastases. Okay, small bowel obstruction. What's the cause in this young patient? Yeah, Crohn's disease. So we've got a inflammatory stricture with what looks like pseudosacculation and small bowel dilatation. And the whole point in doing a CT scan for small bowel dilatation is to find out whether or not we've got a mechanical obstruction, or whether it's due to paralytic ileus, or whether it's due to ischemia. Okay, this patient has had a craniotomy for a brain tumor. You can see the pneumocephalus here, recent surgery, and there's a bit of midline shift still. And then 2 weeks later, what's happened? Could be neurogenic pulmonary edema, or could it be anything else? What treatment would you give somebody with a massive brain tumor? Yeah, it's high dose steroid. This is PCP. Okay, so PCP, and that is seen here. Now, neurogenic pulmonary edema, I like that diagnosis because that would be the differential diagnosis. Don't forget any problem with the intracranial apparatus could cause neurogenic pulmonary edema. Okay, what have we got here? Yeah, myositis. This is a patient with myositis, and we've got increased signal in the musculature, myositis. Okay, this patient has got hypertransradiant left lung, just here, okay? So hypertransradiant left lung, there's a paucity of blood vessels on the left compared to the right. Therefore, it must be a lung problem, not a chest wall problem. And if it's a lung problem, it's something that is associated with a reduction in the number of blood vessels. So it could be a pulmonary embolism, but more likely, this is going to be McLeod syndrome or Swyer-James syndrome. And when we do the CT scan, you can see that already there's a bit of mediastinal shift over to the other side. So any small expiration will cause a mediastinal shift over to the other side. There's a paucity of blood vessels. There's a dilated bronchus, which you can see here, excuse me, which is one of the features of Swyer-James or McLeod syndrome. And we've got normal lung elsewhere. Now, the number of blood vessels per unit volume has decreased because, of course, there's hyperexpansion. So the vessels tend to be smaller than their counterparts on the other side. And that's a very typical feature of McLeod syndrome, as well as the bronchiectasis and the air trapping. Okay, what have we got here? I did a lung biopsy on this particular nodule, and when I removed the pathological specimen from the the actual biopsy gun, it was jet black. Yeah, and we've got melanoma metastases, and the melanoma metastases were due to a melanoma somewhere, could be ocular melanoma, could be on the skin, but the metastases were in the lung and in the brain. And we've got vasogenic edema going up to, but not including the cortex. And this hyperdense metastasis is typical of melanoma. Okay. What do we call this trachea? Yeah, saber sheath trachea associated with COPD. Yeah, well done. So it's just has a very thin coronal dimension. Okay. Saber sheath trachea associated with COPD. Trauma. Yeah, posterior dislocation. So there's a loss of parallelism. So if I could just draw around. Well, that's wider at the top than it is at the bottom. And it should be like that. Okay. So the very fact that it's wider at the top than the bottom should alert you that there's a posterior dislocation. And then there's the glenoid. And there's the articular surface of the humerus. And it's obviously behind the glenoid. So it's the reverse Hill-Sachs deformity. So there's the glenoid, there's the humeral head. So that was posterior dislocation. Okay, so what have we got here? This is a young guy who presents with cold, pulseless legs. And this was done on call. So you can see here that there is an aortic thrombus, and the aortic thrombus is confirmed on the axial views, which you can see here. And just above, we've got normal aortic flow. Now, can you see that there is possibly a small infarct in the spleen? Now, I say possibly because, of course, this is an arterial phase. And if it's an arterial phase, you may not get the full definition. This could actually be sinusoidal filling. But this patient has got an infarct of the spleen, a thrombus in the aorta. Now, young people don't have diseased arteries, so where has the thrombus come from? So if we look a bit further up, you can see the SMA and the celiac axis are okay, the kidneys look okay. And then when we look at the heart has got a left atrial myxoma. And the left atrial myxoma promotes the flicking off of emboli, and those emboli eventually end up going down the leg into the aorta and then embolizing the legs. And in the case of the spleen, there was a small splenic infarct also. How do you describe that spine? Yeah, rugged Jersey spine. So alternating bands of sclerosis and normal low density. Yeah, rugged Jersey spine. Renal osteodystrophy. So it's a combination of hyperparathyroidism and osteomalacia. Rugged Jersey spine. Okay, this patient is a 10-year-old boy and he presents with a pneumothorax. Yeah, osteosarcoma. So this is a Hickman line for the treatment of a malignancy, and the patient is presented with a pneumothorax because they've got an osteosarcoma met. Now, osteosarcoma mets are very, very common as a cause of a bronchopleural fistula. And what they do is they introduce gas into the pleural space because of this bronchopleural fistula, and they present with a pneumothorax. Okay, patient's got emphysema. What's the normal variant? Tracheal bronchus, yeah, tracheal bronchus. What's this condition here? Osteopoikilosis, yeah. And we do nothing about it, okay? Because this is not associated with any pathology. So it's a leave me alone lesion. And they tend to be around the joints, torpedo shaped bone islands, which are orientated along the long axis of the bone. Okay, now this is a great, great film. Okay, this is a really, really good film. So have a look at this. This patient has got cystic lung disease. They've also smoked. Okay, so there's a combination of emphysema. But if I tell you that as well as the emphysema, there is cystic lung disease there, what is the diagnosis? Not LCH? Over here. What can you see there? Neurofibrometer. Okay. So could this be neurofibromatosis? And in fact, what we're seeing here is a mixture of emphysema and cystic lung disease. And there's a neurofibroma, there's a neurofibroma, there's a neurofibroma. So this patient has got neurofibromatosis. So looking at the chest X-ray, you can see the neurofibrometer here. And so the cystic lung disease is associated with neurofibromatosis. And the patient also happens to be a smoker, which is contributing to the volume expansion. So some of these are cysts and some of these are areas of emphysema. Another patient who's got neurofibromatosis. So we've got lots of neurofibrometer just here. A bit more challenging to see, but do look for neurofibrometer in the exam. Really a good example of nodules, and the nodules are in which part of the lung? They're all well ordered, and yeah, so particularly in this part here, you've got little dots which are coalescing, becoming fluffy, and they're all equidistant. because they are in the center of the secondary pulmonary lobule. Okay, there's an area where there's a bit more of coalescing, but these are all separate dots. And what's going on here? This patient is coughing up. Oh, sorry, before I forget, central lobular nodules, hypersensitivity pneumonitis, that's the main one. But anything that involves the airways, and that could be endobronchial tuberculosis, it could be thoracic lymphangiectasis, where you get lymph going into the bronchus due to a problem with the thoracic duct. And this is thoracic lymphangiectasis as it happens, which is extremely rare, but it's just a great example of central lobular nodules. The number one diagnosis for something like this would be hypersensitivity pneumonitis. And this patient is coughing up purulent phlegm, and this turned out to be just a lung abscess. Okay, but could it be a patient who's got a cancer? Well, yes, of course it can. All right, but this patient just turned out to have an abscess. So the point about this one is an abscess can look very much like a squamous cancer and vice versa. Could it be TB? Yes, it could, but less likely, I think, given the scale of the cavitation. Okay, this patient has got a poor malabsorption record, so they're not absorbing stuff very well, and they've got a slow transit of barium through the bowel, and there's a stacked Coyne's appearance, scleroderma. Yeah. This patient is being investigated for query secondaries with a head and neck cancer. Yeah. Cigarettes, left upper lobe. Sorry, left upper lapel pocket. Cigarettes. Okay, what's the diagnosis here? Not Lisfranc. There's no history of trauma. Psoriatic feet. Look at these feet. So if I zoom this up, that's almost like a licked candy stick appearance. There's new bone here, almost a pencil and cup deformity, erosion of the terminal phalanges here, and we've got new bone formation here, erosion of the terminal phalanges. This is psoriatic change. Okay, this patient is complaining of left-sided hip pain. Not a serous mass, but we've got a bone lesion here, left iliac Mets, I'll accept that. The cortex on the right, compare it with the cortex on the left, and we've got destruction of the cortex, and there's a lucency, which is not due to bowel. That lucency is bowel, that lucency is a bone destruction. So we've got a bone metastasis or myeloma in the left iliac blade. And if you're talking about metastases, it could be coming from the breast, bronchus, thyroid, or kidney. Okay. Okay. This patient has fallen on the outstretched hand. Enchondroma. What about the scaphoid fracture? Yeah, so we've got an enchondroma and a scaphoid fracture. So this is where you've got two pathologies on the same film. You all know that, don't you? The more I practice, the luckier I get. Okay, what is that thing there? Patient with left eyelid pain. Yeah, it's either an mental infarction or more likely epiploic appendigitis. And so this is it in several planes. So we've got the inflammation around the twisted appendix epiploica. We've got it here, and we've got it here. And the importance in making the diagnosis is to establish the diagnosis, make sure there is no other surgical cause for the patient's abdominal pain, and then tell the surgeons, look, this is a self-limiting condition, epiploic appendigitis. You don't need to do anything dramatic with this patient. There it is there. What's causing that calcification? Scleroderma, yeah, it's called calcinosis cutis. Osteopoikilosis, another case. That's what it looks like on CT, osteopoikilosis. Have a look at that. What's the treatment of a mental infarction? Nothing really. Just leave it. Give them paracetamol, non-steroidal anti-inflammatory drugs, and just leave the patient. Okay. And it tends to get better. This is gout. Yeah, we've got juxta-articular erosions, very, very marked erosions. And don't forget, the soft tissue swelling tends to be dense in gout because the uric acid gets impregnated with calcium. Okay, what's going on here? Yeah, polio. So we've got a gracile femur on the right, short femoral neck. The iliac bone is stunted compared to the one on the left-hand side. And the muscles are making this look more loosened than the left side. So we've got muscular atrophy, which is acquired from the polio. And there you go, you can see the absent muscles here. So this was old polio, well done. Pneumomediastinum in a patient with a tracheostomy. So there's the mediastinal line. So the parietal pleura has been stripped off the mediastinum. There's gas in the supraclavicular fossa. So this is a patient with pneumomediastinum. Candle wax dripping down the metatarsals equals malariastosis. Yeah, it's one thing saying it, but spelling it is another. So it can be quite tricky. The examiners probably won't ask you to spell it. That's my own candle, and I took that myself. I never take photos from the internet if I can get them myself. So I lit the candle and I did it all for medical education. And there's the candle wax. There you go, just the malariastosis. Okay, I'm very grateful to Raghu for sending me this one. This is a liver spleen scintigram. Liver spleen scintigram. And where is the spleen? Where is that spleen? It's an intrapancreatic spleen. Yeah, it's quite unusual, but it is well described. intrapancreatic spleen. No problem with this one. Patient's got lung cancer, but they're also complaining of left shoulder pain. That rib has gone up in the left-hand side. Second rib, let's have a closer look at that. And you can see that the rib has been destroyed. There's a soft tissue mass in association with this bony destruction. So this is a right lower lobe carcinoma with rib destruction involving the left second rib. Okay, what have we got here? LCH, yeah, we've got lots and lots of cysts in the mid and upper zones and relative spurring of the CP angles. Okay, and most of the disease is confined to the mid and upper zones. And so this is Langerhans cell histiocytosis. And they're the typical higgledy-piggledy cysts of different shapes, different sizes, with nodules of different shapes and different sizes. And again, CP angles relatively spurred. That's my dog wagging his tail, by the way, it wasn't me. And just a little bit lower down, further lower down, lots of cysts, lots of nodules. And as we go towards the lung base, relatively not involved. Okay, I'm going to make this the last one. This is a patient who's got abdominal pain. You shouldn't see triangles of gas. So that triangle of gas is free gas in Morrison's pouch. And we've now got Wriggler's sign. We can see both sides of the bowel wall here. And this patient has got a pneumoperitoneum. Commonest cause will be perforated duodenal ulcer. This is probably fibroid uterus calcification. Right, so I've finished. I'll see you on Thursday at 5:30. Thank you to everyone who has donated a small amount of money. I'm very grateful. Thank you for that, and I'll see you on Thursday. Hope you enjoyed it. Cheers.
Here comes the flood again. Watch it fall from the sky. Feel it soak through my flesh and my blood. Feel it burn in my eyes. When I say how much more can I take? I know the water's rising. Watch the waves crest and break, and though I made nothing but a sound, I fear that I may drown. I fear that I may drown. Here comes the wind again, cold that cuts to the bone. Pack my bags and I'll head out the door. Here I am on my own. When I say how much more can I stand? I know my walls are falling down. I left the rocks and chose the sand. And though I've no one left to just your name. So now the end, what I've been running from. Though I've tried, I cannot lift my head. Oh, what have I become? When I say how much more can I take? I know my time is running short. I am broken and I'm breaking, though I've worn myself so thin. Coming home again. And though I do not know my heart, well, I know myself down to my bones. But if my bones should come apart, then I'll have nothing left to give. But if you take me in, coming home again. And if you take me in, coming home again. Let the water come down from the well, from the well. It's been dry for so long in these hills, in these hills. Oh, I've seen the sky, I've seen the ocean blue. I have walked through valleys, felt the wind move. Hold my hand for tonight. I'm afraid I can't sleep. Wear my heart open wide, all my fears, all my dreams. Though the night goes slowly, dawn will take its time. What I need to make of love and lost life. Well, I won't back down from the riddle of it. I'll find my way. I'm not satisfied in the middle of it. There's more to say. In this life, if I fall, shall I rise? Or shall I weep? If I give it my all and I fail, am I weak? Oh, the flame that burns inside you starts to fade. If you refuse to get back up and just hide away, so I swept over me like a raging sea, lashing and crashing my side till I just gave way. You were the tempest tossed, given up for dead and lost, and you sailed out the eye of the storm. You were the eye of the storm. And you left me behind when you severed all ties. Sworn lone drifter you'll be, but you'll never be free. Oh, oblivion bound, you'll never be found. You'll sail on the eye of the storm. You're the eye of the storm. So high on the seas you roll, a sack of skull and bone, all plunder and pillage inside, roving, roguish kind. Well, if time hasn't touched you at all, you're still the same as before, still plowing and cursing the deep in your man of war, with all the whiskey and rye and a curse on your mind. You sail on the eye of the storm. You're the eye of the storm. From time to time, you still call across my mind, just a mumbling, stumbling thief in the black of night. Up